As you can see, we had to make some changes in the calendar. I do not like to make changes in the calendar, but when we looked at the whole picture, and sometimes we think we have it perfect for you guys, but then when we look at the whole picture, sometimes we see things, that is not going to be educationally sound. And the test yesterday or today would not have been educationally sound for you, because this material is so vital, and I don't want to test you quickly. I want you to be able to have an opportunity to digest it and understand it, because it is so vital. So I hate that we had to make a change, but I feel like the change was beneficiary to you. Just like every other change that we make, in that we are not perfect by any means. I think I am. And I will be the first one to say, you know what, I need to look at this again, because I'm accountable for my actions, and I'm accountable for what I do. And my job is to make sure that I give you every opportunity to be successful. So that's why we changed the test. I know a lot of you are like, okay, oh my gosh, she's going to change this, she's going to change that. But remember that we're changing it for you, and to make sure that you are going to be able to digest this material, because this is going to be, besides my respiratory, this metabolism is the toughest unit this semester. Okay, so I want you to be able to, they're being too loud up there. They say I'm loud? What is that with them?
Party.
We're partying. So I'm sorry that it inconvenienced anybody, but remember, we're doing it for you. So the test will be Monday, and then I'm going to go ahead, Miss Ward was going to come in at 11 and talk to you. But then I got to thinking last night, you know, my mind never stops thinking about what I can do to make this better. I got to thinking, I thought, well, you know what, let me lecture all day today, and then Monday, after you take your test, I won't be giving you any new information. So I might just, if I lecture, I may lecture just like an hour, because I know you're going to be studying, you're not going to read my stuff, I know that. So I may just sort of not lecture, I hadn't decided yet, and then let Miss Ward come in, and we may not be here till 12:40, like I had originally put on the thing. Okay? But there again, I got to make sure that I get through my stuff. So if I lecture till 12 today, I'm pretty sure I'll get through pre-op. So I usually take one day to get through each section. And some people were saying, yeah, I heard this was not an easy, nothing's easy in nursing school, but this is a more or less, it is what it is unit. Okay? The other thing I want you to understand is that the intra-op, which is in the OR, and post-op, immediate post-op, is considered a specialty area. So State Board of Nursing doesn't test you on specialty areas, but the very minimal information. Okay? So I'm not going to be telling you, okay, as a scrub nurse, you're going to need to know what the hemostats and this is and that is and that. State Board of Nursing is not going to ask you that. I'm not teaching you that. There's no that's a nice to know. I know some people go in the OR and they're like, what's this? What's this? Well, that's a drill. That's a hammer. All you need to know. Okay? You don't need to know those instruments, because that is not, you will be trained on your job. So I have, I want to get through pre-op, and hopefully we'll get through that. And then intra-op is going to be more of this is all you need to know. Okay? All you need to know about this, because it is a specialty area. Now, post-op is where we're going to hit it hard. Okay? Because you're going to see post-op every day, right? You're going to be taking care of patients post-operatively every day. So that's going to be the biggest hunk of this information. Okay?
Pre-op is going to be just, okay, this is what it is. This is what we look at. This is stuff we've talked about over and over and over again. As far as looking at age and look at developmental and that kind of stuff. So, that being said, does anybody have any questions about how I'm going to handle this? Okay. Also, special testers, when we make a change in tests, you need to be the ones to contact the student services. So, I've talked to Joanne this morning and told her the new schedule. So whoever special tests, I've already done that for you. Okay. All right. So any questions about how this is going to roll? All right. That's not really pretty. It's pretty, but it's dark. Yeah. All right. Let me see what I can do here. Better. Let's see. Well,
yeah.
You can see
That's
that
better.
You really don't need to see my name. All right, so let's start with our surgery. Everyone knows what surgery is. It's an invasive procedure that we do either to, or the surgeons do to diagnose a problem. Do we treat an illness or an injury? And the good thing about the preoperative period is you've got to see there are multiple, or we call it multidisciplinary people that work together. It's not just one person that handles everything that has to be done as far as preoperatively and as far as surgery. Those of you that went to surgery last week, I was reading your Blackboard stuff and your discussion boards, and I started looking, and one of the most common things that people were saying was teamwork. I saw teamwork. Well, this is one unit that you're going to see absolutely amazing teamwork, because I can't just do it by myself. A nurse has got to work with, we end up working with the chaplains, especially if the patient has a bad diagnosis. We're going to be working with physical therapy. We're going to be working with occupational therapy. We're going to be working with the pharmacy. We're going to be working with the surgeons. We're going to be working with everybody during this pre-op, post-op, and intra-op. So it's a lot of teamwork that happens when our patients go to surgery. Now, there's different reasons why we have surgeries. And I just use the term purpose of surgery, which is more or less the reason why we're having surgery. One of the first one is to diagnostic. And diagnostic means I got to figure out what is going on via some more information. So in other words, the patient comes in and they have a huge knot or mass in their breast. I've got to go in and biopsy that to make the diagnosis. Okay, so that's what we're looking at here. So when we actually do a needle biopsy with that, that's a diagnostic, because that's going to give me a lot of information. Some of your patients might have even had a bronchoscopy. Some of your patients had bronchoscopies. You know what a bronchoscopy is. It's where you actually they put a tube, and that's considered surgery. They actually put the tube down into the lungs, and they look around. And that, they may see a nodule, they may see mucus, they may see anything in there, and they take biopsies of it to assist them in diagnosing what the problem is. Okay, so that's the reason why they're having what they're having. So diagnostic is one of the purposes. Another one is curative. And that means that we're going in to try to cure whatever's wrong. In other words, if you've got someone who has got extreme pain in their lower right quadrant, and they do a CT or something, and they see that the appendix is large and it's inflamed, well, they're going to cure that by going in and getting that appendix out. So that's like, we're fixing this. We're curing the patient. Now, is a cancer patient going to be like this? This is not going to be a cure a lot of times. But it's an organ that is not working right. Something's wrong with it. I'm going to go in there. I'm going to get it out. And you're going to cure it. Another thing is, a lot of times we see our diabetic patients have their lower extremities, what? Amputated because of
Poor tissue perfusion.
perfusion. And it's poor perfusion. Okay? So they're not getting what they need. Don't y'all like my voice? I should have been a singer. They always ask me at church to sing at Christmas and at Easter. And I say, I'm just making a joyful noise. I'm not singing real pretty. But anyway, I thought I'd sing for y'all this morning. All right, so amputation, that may not, and I know you're thinking, oh my gosh, it may not cure it, but right now it's curing it. If those toes are dead, if those toes are black, and I cut them off, or the surgeon cuts them off, then right now he's cured. Does that mean that it's may possibly not go up? Now, if he's a non-compliant diabetic, then there's a possibility that it might have to go up. But for right now, we've got it cured. So that's another reason why we have surgeries. Cosmetic. We are seeing a lot of cosmetic. That is an elective surgery. Okay, a lot of times, insurance don't cover that. I had a breast reduction in 2008. That was cosmetic. I had to pay a lot of money for that. But that's an elective surgery. Does that mean that I treat them any differently? Absolutely not. It just means that the reason why we're doing this surgery is for cosmetic purposes. There's nothing else going on, that the patient's not sick. Okay, they're just doing this to enhance their bodies. Palliative. I think this is one of the hardest times when we're in the OR, is seeing that we're doing this palliative. And you know what palliative means. It means we're doing this surgery and this person is not going to get better. They're not, it's not a cure for them. But what I'm doing is I am assisting, the surgeon is doing a procedure, surgical procedure, to assist the patient in being able to live longer. So there's not a cure for that. And a lot of times we'll see patients who have huge tumors in their intestines, and it's cancer, and it's spread all over their body. But that tumor, part of that intestine has to be moved out. And so they have to have a colostomy, and everybody knows what a colostomy is, right? So that's not saying that just because I did the colostomy means that they don't have cancer anymore. Does that make sense? I'm never going to cure them from this. But I am going to put that colostomy back on because they will have bowel function through that way, whereas they could not have functioning if that tumor or that blockage was right in the way. Okay, so that one's really hard to know that the patients are having to go through a procedure like surgery and not have a cure. So it's very difficult sometimes to see. Restoration, those are the ones that we see, like a patient has a knee that is rubbing bone on bone. And obviously they can't function like that. They can't do the ADLs. They can't walk around. So what we'll do is we'll go in and do a prosthesis on the knee that's bad. Some of you got to see some knees this past week in the OR. Amber got to see a lot of knees. Did you get an opportunity to talk to the patient about why they were having that?
One guy was just extremely overweight.
Yeah. So obesity is also going to be a big existing factor, a pre-existing factor that would cause us to have the patient to have.
The other one was 85, so.
Yeah. Yeah, they were a little bit older and bone into bone and very difficult. So that's another reason why we do this. You also see another skin grafts is another thing that is restoring the skin from whether it's a burn, whether it's a decubital ulcer that wouldn't heal. That skin, they're going to take skin from somewhere else and put it on there to try to restore what the patient had before. Okay, skin grafts are very, very hard to heal, and you can imagine we have to be very, very careful with skin grafts because they can get what? Infected very, very quickly. Very, very quickly. So infection is going to be a big deal with restoration a lot. Transplant, heart transplant, when someone's organ has lost all the function, unable to function on its own, and so they are given a whole new organ. And I'm sure y'all have heard about organ transplants. The bad thing about organ transplants sometimes for the patient is that they have to wait. That is one of the hardest things for them. They know that their heart's not functioning correctly. But the bad thing is we've got to wait on someone else to expire before they can make that transplant. So those are the purposes and the reasons why we have the different surgeries. And we'll talk more about the different types in just a minute. All right, why do I have surgery, or the urgency of surgery? There are different categories that we can use to see why do we have, how fast do we need to do this surgery. In an elective surgery, is that something you think is going to be really, really fast? The patient goes in, talks to the surgeon says, okay, I'm scheduled to be in the OR on Thursday, all day long, you come at 9 o'clock. Okay, so there's no urgency there. We just go in there and schedule it and we're good. Urgency. This is where we come into effect so much based on our assessment skills. Because we're going to be taking care of patients that based on our assessment, I've got to see if they need to go back to surgery. Okay? This is going to be about 24 to 48 hours when you see that an intervention is going to happen and it needs to be done within 24 to 48 hours. One of the biggest things that we're going to see, I hate to keep popping to post-op, but post-operatively, patients have a tendency to develop, have their bowels just don't want to work after they get up from wake up from anesthesia, because when they get anesthesia, everything stops working, and the bowel does too. So I've got to be watching my patient because they can get an intestinal obstruction after surgery. So let's say they went in and had a breast reduction. They were under anesthesia, but their bowels just didn't wake up. So based on my assessment as a nurse, I got to keep that in my mind constantly. And I really get on patients about, not get on them, but you know what I mean. Get them up post-operatively. Get them up. Because if we get them up and get them moving, we know that that's a risk. And I don't want to make them, they just went through surgery. I don't want to have something where they have to go right back to surgery. So urgency is, we got a little bit of time to play before we make that decision. Emergent, we don't have no time. We got to go. And one of the most common ones, since you're getting ready to go to OB next semester or next course, is OB is one of the biggest reasons why we have to take a person back to surgery immediately. And what happens is after they deliver, they bleed, and they bleed, and they bleed, and they bleed. And I can't control it, no matter what interventions I'm doing as a nurse to stop that bleeding. It's not being stopped. So I've got to take them back to surgery and figure out where that source of bleeding is and fix it. Another thing is aneurysms. Have you heard about aneurysms? A lot of times with patients who have aneurysms that rupture, they don't make it because it ruptures and they bleed out so quickly. So as a nurse, isn't it vital for you to assess your patient about bleeding? I mean, it is vital. Sometimes the bad thing is we can't see that blood, can we? We can't see internal bleeding. So you have to watch what? My H&H, right? H&H. So what if a patient had abdominal surgery? What would you think their abdominal area, or not had surgery, but if they were bleeding internally, what do you think their abdomen would be like?
Rigid.
Distended.
Very distended and very what?
Rigid.
Rigid, hard. The touch, when you touch it, is just as hard as this right here. So those are things that you've got to keep up with your assessment to know that I got to make sure that, especially one of the first things you may see is your H&H going down. And you're like, oh my gosh, I don't know what's going on. My patient's H&H was 12 and 36 when he came in here yesterday, and today it's 4. Oh my gosh. And that may be one of the first signs that you see. So based on your assessments, you got to figure out, does this patient got to go back to surgery? Now, obviously, you're not going to be making the decision, but through your assessment is going to help us decide what we're going to do, because it's a life or death situation. Life or death. Through your assessment, you can save someone's life if you assess the patient to make sure that they're not bleeding. What do you think that pulse is going to do? Going to do what?
Go up.
And what do you think that blood pressure is going to do? It's going to drop. So isn't that going to be one of the first things you do? Get in there and check those vital signs. You got somebody whose pulse is 120, and then you do the blood pressure, and it's 80 over 40. We're worried about bulimia. Hypovolemia. Like, what am I saying? That's what I'm worried about. That's what I've got to get you to start thinking. Oh my gosh, this pulse is high, this blood pressure is low, something's going on, and you may be that one person that does that through assessment. See how I'm stressed y'all about assessing the patient? You gotta assess them and see what's going on. All right, so there's the urgency. The other degree of surgeries are either minor. My personal opinion, which nobody cares, my personal opinion is, I think anyone who has surgery, period, I can't look at it being minor anything. You know, when you have drugs on board and that suppress, like Bella. Is that right, Bella? Ella. Close. You know, hers was they consider minor surgery. But I can't look at any surgeries being minor, because I just put a baby who's 18 months old, or 19 months old, under anesthesia. What are the side effects of anesthesia? It's not minor, but our book, that's just my personal opinion. I'm going to watch everybody, whether it's a minor surgery or a major surgery, I'm going to watch them, because I know they've had anesthesia. But it does... The thing that the way they classify it just means that the complications from the surgery are minor. Okay, I don't think any surgery is minor, but the complications, like it's less of a risk for them to have these type of surgeries. And we'll get into the different types, like conscious sedation and local anesthesia and that kind of stuff. So those, like with an IND, like an incision and drain, some patients may not have to actually be put to sleep for that, but they're given some medication to sort of make them look like Ella, or they'll localize it. Okay, but it's still anesthesia. We'll talk more about anesthesia when we get into the intraoperative. And then, of course, the major surgeries, we've got to look at patients being put to sleep and being cut on, that we know that blood loss can happen. That's why I've got to stress to you important to look at that blood pressure, look at that pulse, look for any signs, look at that incision, look for signs of bleeding. We've got to look that their vital organs may have been jeopardized, okay, as we're doing the surgery. And they are more at risk for post-op complications, and we're going to talk deep about post-op complications one of these days. That I don't know which day it is, but whatever day I get to it. So post-op complications is very more likely to happen. So you knowing that, you're going to be on it, aren't you, post-operatively? And we're going to be doing interventions to assist that patient to not have the complications. Okay? I remember when I had my hysterectomy, the next morning they looked at me and said, "Get up." I said, "Not getting up." They were like, "Get out of bed." And sometimes I feel like that's the way I am with my patients. I know that it's going to hurt. I know that you don't want to get out of bed, but we're going to. Okay, so you got to be very, very. And the other thing, what would you do if a patient comes in like me and said, "I can get up"? I can do different things, but as far as education, what do you need to do? I need to tell them why it's important, because some people don't know that their bowels might not be working. Some people may not know that they could get pneumonia if they don't get up. So educate them, and I guarantee you, once you say that keyword, pneumonia, they're going to be getting up. Okay, because who wants pneumonia after they get out of major surgery? So get them up and explain to them why we're doing what we're doing. I'm going backwards again. All right, so any questions so far about the reason why we do, or the purpose of doing surgery, the urgency of it, anything like that? Like I said, this is pretty straightforward information, and it is, but my little post-op is where we're going to really hit hard. All right, let's look. Oh, wrong one. We didn't talk about that. All right, let's look at the different surgical suites. I know that a lot of patients are wanting to do their surgery, if possible, outpatient. Do you know what I mean when I say outpatient surgery? They go to this facility, they have their surgery, then they go home. Okay? A lot of times, insurance dictate if we do inpatient or outpatient, and that drives me crazy because I don't like insurance. I don't like them dictating what needs to be done for my patient. But that's the way it is. So when we talk about outpatient, there's an inpatient and an outpatient. The biggest thing that you have to remember when you have a patient that's in an outpatient setting, there are certain things that have to be met before they go home. So as they went through surgery, they have been to post-op for about an hour, hour and a half, 2 hours. Then I have a certain amount of criteria that have to be met before I say you can go home. One of the things is they have to be oriented. We have to be able to wake them up, and they know where they are, what's going on, who they are. I don't care if they know what time it is, because after I've been in surgery for a while, I don't care what time it is either. But we've got to make sure that they're oriented. Another thing is I want to make sure that their pain is controlled, because I can give them pain medication because they're going to have a driver. I can give them pain medication. If I see that they're hurting, I can medicate them before. I want their pain in control before I make them walk out to the car, get into the car, ride home, get out of the car, go into the house. All these things that may be very simple for us to do without having surgery, but they just had surgery. So I want to make sure that I get their pain under control. Another thing I want to make sure is that they void. They have to be able to pee. Why do you think that's so important? Because they've had anesthesia. And with anesthesia, what happens with anesthesia? Everything stops or gets lazy. And being able to void is very, very common that they can't, because everything's so relaxed. And they just, whatever. They cannot void. I have to make sure, because remember, I would probably give them a lot of fluids in the OR. And don't I need to make sure that that I equals that O? So I've got to make sure that they pee. I need to make sure that they can stand and walk on their own. Not meaning that I'm going to get them up and say, walk down the hall by yourself. I ain't going to do that. I'm going to get them up, and I'm going to get them up how?
Slowly.
Very slowly. I'm going to have them do what first?
Sit
I'm
dangle.
going to have them dangle. Then I'm going to have them stand up, and I'm going to be right there with them, because we have constantly got to be thinking about hypovolemia at this point, because they've been through surgery, they could have lost some blood, and when we are hypovolemic and we stand up, what do you think is going to happen? That BP is going to do what?
Drop.
Bottom down, and they're going to pass out on us. So you've got to get them to be able to stand up very slowly and make sure that they are not, their BP is not out of control. Vital signs, not just BP and pulse and respirations, but I've got to watch that temp as well. Because when we take them into the OR, it's very, very cold. Those of you that went to the OR this past week can attest to that. It's very, very cold in there. And we understand why it's cold, to control bacteria. Little germs don't like cold weather. They like warm weather. So we keep everything cold. So I need to make sure that my patient is able to maintain their temp before they go home. Another thing that we need to make sure is that they understand our discharge instructions. This is where sometimes I have to utilize the driver or their family members, because after patients wake up, they're not going to be able to verbalize a lot of their discharge instructions. So we're looking at pre-op. So what do we need to make sure before we ever give them anything else, any drugs? I got to make sure that they understand what is expected when they go home. So I'm going to be taught, as soon as they decide they're going to have surgery, I start talking to them about their discharge instructions. As soon as I say, okay, I'm having my surgery on February the whatever, and the nurses start, we start, let me make sure that you understand when you go home, this is what you need to be looking for. Because there's going to be information that they have got to call the doctor about, and I've got to make sure that they understand. Like my daughter's father-in-law had hip surgery a couple weeks ago. I had to go pick up something at their house, and he said, could you come here and look at my incision? And I was like, sure, I'll be glad to. What's up? He said, well, I've got a little swelling. I thought, okay. Swelling, because that should have been one thing that they told them. If you start having some edema, you need to let them know. And so as he pulled down his pants, and I look, and there's an incision or a dressing on it, which he was 7 days post-op. Should not have had a dressing at that point. So I pulled the dressing off, and I see all this drainage there that was yellow. And I went like this, and it stunk. And then I looked at the incision, and the incision was right here. There was so much redness, about this much, was just as red as it could be. And it was very warm to touch. And he not only had edema, he had pitting edema all the way down his legs. So I said to them, we're going back to the hospital. You're going to have to go back. But I said to him, your discharge instructions, what did they tell you before you came home? Did you understand that these are all signs and symptoms of stuff that you should immediately contacted the physician about? He said, I don't remember anybody talking to me about this. And his response was, but I'm not running fever. Oh, jeez. Okay. That's a good thing you're not running fever. But we have all this other stuff going on too. So do you see how important it is that they understand these are the kinds of things that you need to let somebody know? And you know what? He had to go back to the hospital. He was admitted for 4 days on IV antibiotics due to infection. So let's make sure that our patients understand you've got to contact somebody because he could have gotten septic and he could have died. So I just want to stress to you, we've got to make sure, and if the family members, when I wake up from anesthesia, it's days. So I always say, make sure my husband understands what's going on. You know, talk to him because I'm not going to remember a word you say. So we have to use the family members. And I always ask patients when they're getting ready to be discharged, who's going to be right there with you? Who's going to be the person that you're going to call to make sure, or who's going to be right there to help you? And I talk to them. Look, I need you to understand that if these things, and I'll write them down, if any of these things happen, you've got to contact somebody and let them know. Make sure we know, because we can stop a lot of things. I can't stop all infections, but if I can educate people, I can maybe get them to the hospital or get them back to the surgeon before they become septic.
I'm on joint camp, and my patient had her knee done, and I got to see her discharged, and they actually print out a whole bunch of papers.
Good.
And my nurse goes through and highlights the main stuff.
Yes.
And she goes in there and says, make sure that you know this.
Absolutely. That's what we've got to do. Because there's so many times, we know everybody that has surgery is at risk for these things. So I'm very proud that somebody's doing what they're supposed to be doing when it comes to discharge instructions. Because I think some people say, oh, they're going home. They're going home. Okay, just give them a sign this paper. That is one of the most important things. When we admit a patient, we should always begin to start talking about discharge.
Highlighting.
Oh, yeah, anything. And I ask a lot of people, and I don't know if y'all even think about this, how do you learn? That's what I do with y'all. Are you a visual person? Are you an auditory person? Can you just read something and you got it? So if I look at somebody and they say, I'm very visual, then I'm not going to give them a bunch of handouts. I'm going to go try to find some pictures. Or I'm going to go find something that's going to help them learn and make them understand. So it's very important. Very important. All right, and then, okay, so that's just some of the introduction to the surgery centers and the surgery, what happens there. So let's look at pre-op. When I talk about pre-op, I'm talking about it starts from the minute the patient decides to have surgery. And they've scheduled that surgery, that's when pre-op starts. And it goes until we're actually taking them into the OR. So we sometimes have a lot of time to talk to these patients, don't we? This is an elective surgery. We've got some time to talk to them and make sure that they're educated. Education is the biggest focus when it comes to preoperatively. And safety. And I'll talk more about the safetyness of it but education, I cannot stress to you enough, we've got to educate this patient preoperatively. We've got to look at some of the risk factors. What's going to put this patient at greater risk when they're getting ready to have surgery? And why? Why is this at risk? I've got to look at my very, very young and my very, very old. My very, very young patients, one of the biggest things with them is temperature. They cannot maintain their temperature well at all when they're put in stressful situations. So when we have a pediatric patient, when we go into the OR, do you think the room's cold? Yeah. It's hot. It's hotter in there because we know that they have difficulty, and I know you're thinking germs, but temperature in this situation is very, very important because the pediatric patient can't maintain their temp as well. So we got to really, really watch that temperature in there. Did I get ahead of myself? Oh, okay, I've already talked about temperature. Let's see here. Look. These are my infants. and my toddlers too, they're a little bit, not a lot, whole lot of difference. Toddlers seem to handle things a little bit better than my infants do. But my temperatures is one of the biggest things. The other thing we got to think about is their blood volume is very small, and they don't have a lot of reserve when it comes to fluids. So we really got to watch that we don't deplete their fluids as much. Now, I know that we just talked about IV fluids and did IV fluids and stuff, but do you realize that with an adult situation, when you're giving them fluids, you're going to be giving them like 100 cc's an hour, 75 to 125 cc's an hour. My infants, you're not going to see that. You're going to see a very small amount, like maybe 10 milliliters per hour or 20 milliliters per hour on a pump, because they can't overload them with fluid. They cannot handle that extra fluid and be able to maintain their perfusion because of that. And they don't have a lot of reserve, i.e. when I give a patient, like an adult, a bolus of 400 or 500 cc's, they can handle it. They've got that extra blood volume that their body can maintain it. But if I give a baby a bunch of fluids, they can't. They cannot maintain their self. That's a fluid overload, and most of the time they'll go into cardiac problems if you give them a lot of fluid. Okay? Most of the time, newborns or infants have problems. It's going to be respiratory. It's going to be a respiratory problem. But if I start giving them a bunch of fluids, it's then going to turn into cardiac problems. So I've got to be very, very careful. I don't want to fluid overload them. They just cannot help themselves because of the immaturity of their lungs. And not the lungs, their organs, all of their organs. One of the biggest things that we want to think about is the babies that are born, their livers are immature. Their liver is immature on infants. So I have to be careful with giving them medications, because what happens in the liver? Metabolism of medication. So I have got to make sure that the medication that I give them is what based? Weight based. Now I know some people were saying that we didn't really talk about, which I thought I did, talk about when we do the calculations for babies, you've got to do it in kilograms. Remember kilograms?
Yeah.
Okay, so how many kilograms are in a pound?
2.2.
2.2 kilograms equals 1 pound. So you're going to see in your, I said it backwards, didn't I? Yeah. 2.2 pounds are in 1 kilogram.
Yes.
I was thinking it, and then when it came out, I was like, wrong answer. 2.2 pounds equals 1 kilogram. And remember, the way we find that information is we go to the drug book. And the drug book's going to say, you give X amount of medication per kilogram. So you've got to calculate per kilogram, change your pounds to kilograms, and then multiply. I feel like I'm sweating. Sweating, y'all. All this working out I'm doing here. You've got to calculate based on the kilograms. So if you've got pounds, you convert that to kilograms, and then it'll say, for example, 0.4 milligrams per kilogram.
Multiply.
And you just multiply. Okay, and that's how you get the dosage to make sure that they got the right dosage. You have to know their weight. Have to know their weight. All right, my toddlers in the pre-op situation, they may be able to understand a lot of what we're saying to them, but one of their biggest things is they're being separated from their parents. How did Ella do?
She was drugged that to,
So that's why we put drugs in them first.
stitching a fit prior to the.
Right. Because of the situation she's in. This is a strange situation. You know, there's lots of people dressed up in funky little things. We got green everywhere. We got things on our head. You know, we've got things on our shoes. We look a little funny, so it's a little bit scary for them. So we've got, and one of the things that I love when I see the pre-op is they make it fun. The pre-op people.
Letting them color on the bed.
Absolutely. Did y'all hear what she said? They gave her crayons and let her color on the sheets. Now when she gets home and she wants to color on the sheets, you can blame the pre-op nurses. But we've got to make it fun for them. We've got to play with them. We've got to, you know, they put her in a wagon, didn't they? Or did they put her in a wagon? We've got to make all this stuff and let mom and dad stay there as long as possible. And then when we give her some Versed, she'll calm down a little bit. But another thing that I love, the way that what I see, now this, I'm just going on what I see at Northeast, is they don't start those IVs on those babies until they get them asleep, which I think is amazing because I didn't want somebody starting an IV on my baby with them being awake. So what they do is they give them some Versed. They gave it to her liquid, just gave her some to drink. Then they give her, you know, that little Lala, that's the Lala, and they get her back, and then they have the mask, and we'll talk more about the way they put them to sleep, but they give them the mask to put them to sleep. And so they get to play with this funky thing, and they don't realize that with them breathing it, it's going to put them to sleep. So then when it puts them to sleep, then they can do the IV. So the babies are not knowing what's going on. So I really, really like that. They're afraid that their bodies are going to be distorted. Something's going to be going on with their body. They may even, the older ones, may feel like they're going to die. We will see this a lot when they've broken their arms or broken their legs. And they think, oh my gosh, I'm going to go to surgery and I'm never going to have an arm. Or I'm never going to have a leg. You know, I'm never going to be able to walk again. So they're very, very scared about not, and it's something that they don't know what's going to happen. They've never been through anything like this before. So they're very, very nervous about what's going to happen with this. The other thing that I do a lot when in the pre-op situation is I always talk to the parents about what kind of terminology they use with the babies. I can't walk in there and say, yeah, do you need a void? They're going to look at me like I've got 3 heads. So I always ask mom or dad, can you tell me what you use to go to the bathroom? When you need to stinky, what do you say? You know, when you need to pee, what do you need to say? You know, that kind of stuff. Use their terminology that I'm getting from the parents. So if I say that same terminology that they're used to hearing, then they develop some trust with me. Oh, you know, you call it stinky too? I do too. You know, whatever. So that I can get them to hear terms that they've heard before, so it will decrease some of their anxiety. My older adults. Now, we've talked a lot about what happens with drugs with our older adults, but let's look. It really is about the same thing when it comes to surgeries, because the majority of the things that we're getting are drugs. So I've got to look at that patient, my older ones, for fluid and electrolyte. So one of the things that I know that I've got to watch for before I go into surgery is what electrolyte? Potassium. Who had the patient who had the low potassium this week before they went to surgery? Who was it? Meredith. Sorry, I didn't see you back. Meredith, tell them what happened. 2 point what? 2.6. Okay, so what did they do? Yeah, if it didn't come up, they were going to cancel the surgery. So you as a pre-op nurse, isn't it pretty important for you to make sure that you check those electrolytes before? Because you may be the one, and that pre-op nurse was the one that Meredith was following, that noticed that the potassium was not good and did something about it. She could have easily not caught that. That patient could have went to surgery and had a heart attack based on the potassium level of 2.6. You've got to look at them electrolytes, especially potassium, because it is vital. That is your responsibility as a pre-op nurse, because you know what potassium does. You know what the electrolytes do. So we gotta know if we're already deficit. I sure as heck don't want to send them to surgery because that could make them more deficit, right? Their kidney function is not as good because of their older age. So what do I want to make sure that I monitor? That they keep my INO, right? Okay, so and I keep throwing the ones that were there because they were the ones that have been there. In the OR, when they did put Foley's in, which was not a lot last week, what were you seeing with the CRNA, with the nurse watching the INO? Where was that? Huh? It's under the bed, so that CRNA that gives the medicine and does everything is looking to make sure that that patient has got 30 cc's an hour, and they keep up with it. Every hour, they are making sure that they've got that patient because they know that with an older patient, fluid problem, kidney function is a problem.
What length of procedure do they determine if they need to put a catheter in? Because I know on day 2 when I was there, they were really short and they did it, and then the first day it was long.
Right, and you're right, it is. If it's going to be a very short, did y'all hear her question? When do they decide whether you're going to put a Foley in or not? If it's a very short procedure, then no, they will, because that's invasive, right? And that's increasing my patient's risk for infection because we're doing that. So it's a very short procedure. No, I'm not going to do it. It's a very long procedure. Yes, we will do it. We will put that Foley in, especially on an older patient, because a lot of times older patients can be incontinent, and you don't want them to not realize it, and they're incontinent on the sterile field, so that's not going to be good. But I know a lot of them, last week, we were just making sure that the patient voided prior to going to surgery. So in the pre-op situation, we gave those patients one more chance. Do you need to go potty? I need to make sure that you empty that bladder before you go in there. So, but the majority, if it's a long surgery, they're going to go ahead and put the Foley in anyway.
So I know normally they take months to either surgery, they have a Foley.
No, nothing. And we'll talk more and more about not eating later. Yeah. Oh, yeah. Oh, cool. Oh, cool.
And it was sold recently. It was just
Yay. Yeah, and this, since y'all are having this in class now, if any of your patients are in med surgery and go to surgery, you can go. You can go with them, even if you hadn't had the didact. I mean, you can go, and I want you to go.
What are they doing in a situation so far in Foley where it was supposed to be a shorter surgery and they get in there, like mine expected to do the surgery, and they're like, oh, it's gonna be an hour, no problem. And they got in there and the scar tissue had basically hidden everything, and it wound up being like 4.5 hour surgery.
Yeah, they may go ahead and go under. What they'll do, and when you get into the OR, you'll see that everything is draped. And what they will do when they see that we went from an hour to 4.5 hours, then the nurses will get under there and put a Foley in under the sterile field, which is very hard to do because you don't have no light, everything's dark. Somebody has a flashlight so you can see, so they may have to put a Foley in after the surgery starts. Yes.
I had an ankle surgery, and before they had me go to the bathroom, but then they put the block down my leg, and right before they went to take me back to surgery, I started freaking out, and I had to go to the bathroom, and they were like, oh, don't worry, we'll take care of that.
Yeah, and sometimes they just do it in and out. Sometimes they do. Somebody got to see it in and out this past week. I don't remember who it was. Amanda got to see an in and out. And one of the things I try to get y'all to do your Foleys when your patients are asleep, But since they were just doing it in and out, they went ahead and did it. But me and Amanda were in there with them. And one of the biggest things that we kept saying was, Amanda, look at this meatus, because there's going to be a lot of meatuses that don't look like this. Because as soon as we separated her, it was like, here I am. You know, didn't have to go digging, didn't have to go nothing. So that's one of the biggest things I want you to when we get in there, doing a sterile procedure, but finding that meatus is, but hers was very shining at us. So that was good. But yes, we will, they may just do it in and out of you.
At work, I had a very there last week or 2 weeks ago, and she came in with a left hip fracture, and she was up on her floor, we set up taking her to the surgery, they put her to her floor first, and then they had me up on there, that way everything would be in place for the back surgery, and it wasn't like terrible hard, but that was the first time that I had placed a ball in somebody who couldn't move both legs.
Oh, yeah.
And so it just went all on this leg as far as she could get it, and I couldn't move the left leg, so that was good.
So it's really better if we do put them in the OR, because if we would have, you had to be very careful in moving her, because you knew it was going to cause her a lot of pain. So when I get her in the OR, it's better to put the Foley in, move the leg, and she's not feeling it. Yeah. So they are hard. They're not always easy to do. All right, so we know that the healing process may also be altered when, so that's more for post-op, so we got to watch them. Sensory function, they may not be able to hear us, and they may not be able to see. So we need to make sure that they can hear us very well and make sure that they can see what's going on. All right, immune function, we know that they have a decreased immune function. The wound healing, and liver function. We've already talked about this in medication, so I think this is sort of a review that you know that older people have these issues. So you know older people can't metabolize those medications, so they hold on to them, so they may be more difficult to wake up. I've got to make sure that I understand that wound healing is so important. What kind of things do you think that, because another thing is nutrition is not good with older patients either. You know, they come in and they just eat whatever they want to eat. They don't get the adequate nutrition. So what kind of things do you want to make sure post-operatively that you want to get them to eat? Protein and vitamin C. Absolutely. Those are two that are going to assist us in helping with wound healing. All right, so we've looked at the different developmental problems. So now let's look at our patient's general health. Mind you, we are in the pre-op period still. So when I look at my patient in the general health, I've got to look to see if they have any drug or substance abuse. We see so much tobacco use. Not just smoking cigarettes, but dip and all that kind of stuff. So we've got to sit in because we know that patients who smoke are at risk for respiratory problems post-operatively, right? So I've got to make sure that I understand that that CRNA knows that they're a smoker and knows we got to do what we can to prevent this from their respirations, making sure that their respirations are okay, making sure that they have a lot of secretions. And I know that one of my best friends is a CRNA. Everybody that smokes, she sets up suction for. Because if they have, now obviously I don't want them to have a lot of secretions when they come in for pre-op, but she always has suction set up just in case they start coughing and they get some stuff up and she can suck it right out. So it doesn't clog their airway. But another thing that we see a lot on is our patients who come in and are alcoholics. It's very, very hard to see someone come in that is addicted to something and then we say, you can't have it right now. So we may see our patients going into DTs. So we've really, really got to watch them because once we start giving them drugs, or giving them medications to help them go to sleep, we may see that what we give a normal, I don't want to say normal, a person of this age getting ready to be put to sleep, the CRNA might just give this dose. But with an alcoholic or a drug addict, they're going to need a lot more to put them under. Okay, so they're going to need lots and lots of meds. And we've got to watch them very, very closely because I don't want to OD them. And they may, I remember my dad was not a drug addict, but it took so much medication to put him under. And they asked him, have you ever been on drugs? And my dad was like, he was just a fussy. But it just takes a lot of medication to put him under. Everybody's different. I can sniff it and I'm out for days. Okay? But that just tells you that different people react different ways. But my patients who've got a history of drug abuse, I've got to watch them. Because I can give them lots and lots, and they may OD on us.
I had a patient, he was going in for a CEN, and he smoked a pack and a half a day. And then I also saw he had dip, which I mean, he was back to his fiance, or I was going to throw it away.
Good for you.
But I was upset because I didn't know what it was. And then I was like, hey, what are you doing? And he said, oh, I'm eating dip. And I'm like, I've never seen that kind of dip before. So it's a nicotine dip. And I was like, you're altering my care plan. He already had a nicotine patch on, so I was kind of pissed. I was like, well, give it to me. He had two of them on his desk, so I told him to give it back, and I went to the bathroom to get something. And she gave him one, like I said, I'm going to throw it in. But anyway, so he was going
you can give it to his family.
Yeah, I mean, she
just give it to her.
She took it, but then she gave it some back, and I was like, I'm going to throw it away because it's back to him. I said that, whatever. He went with TN, and the nurse was pushing some drugs for him, and he was still awake. So the doctor said, okay, push some more. So some more. And then it took us those 35 minutes, no, almost an hour to wake him back up. Yeah. So she was like hitting his chest and doing everything to wake him up. Like, I mean, really hitting him.
So what happened, it took a lot to get him under.
Yes.
And then it was going to take us a lot of time to get him back up.
About 3 times the amount that they were supposed to give, like for a regular patient, I guess. She kept on pushing and pushing. She was like, okay, she's still awake. And like, you just move and get up, he's still awake. And then keep on pushing the drugs.
Yeah. Then, so it takes longer. And see, that's both scary, isn't it? Not knowing how much medication we got to give him to put him under. Because I don't want him feeling anything.
No.
No, don't want him feeling anything.
The second patient I had on the first day was that lady that had fibromyalgia, really young, and the CRNA said she was trying to find a different drug that her liver hadn't seen before she gave her anything that she had had before at higher dose.
Oh my gosh, that's amazing. Yeah. Did y'all hear that? So the CRNA knows that this patient has a history, fibromyalgia, and she was going to try to give her some medication that the liver had not seen before, hoping that it can metabolize it better and her be able to not have the side effects or not be so difficult to wake up. So, I mean, that to me, I'll get on my little bandwagon in just a little bit with the CRNAs, and I love them. Love them. They're amazing. In my next life, that's what I'm going to do. But anyways, so I just want you to realize that how important for patients to have some type of history, how it's going to affect them and being put to sleep. It will have an effect on them. All right, malnutrition, we just talked about that. We know that it's going to alter our wound healing. We need lots of calories, lots of protein, and vitamin C. Obesity, did y'all just talk about obesity? So obesity has some issues as well with wound healing. And remember, our patients are going through surgery. They're all going to have a wound. So if they're obese, they're going to have trouble with getting them their wound healed. The other thing that they're going to be very, very high risk for pneumonia. Very, very high risk for pneumonia and cardiac issues. But those are the people that we've got to get up. And if we have patients who don't want to get up, we've got to do other things like in-sim spirometer, turn, cough, and deep breathe. And we'll talk more about things that we can do. All right, do you think we need to take a break real quick? Yeah. Sorry. All right, this will be a good place for me to stop, especially since y'all just talked about obesity.